Hello, I'm John McMurray from the University of Glasgow in Scotland in the United Kingdom, and I have the difficult task of summarising how we might optimise the treatment of patients with heart failure and reduced ejection fraction, looking at the new guidelines and beyond, and I've got to try and do that in just 10 minutes. So these are my disclosures. So let's look at the new treatments that were included in the 2021 guidelines. And basically, there are two types of new therapy that have been included on the basis of positive trials conducted in ambulatory patients with heart failure and reduced ejection fraction. The first two I want to talk about are the Emperor Reduced and DAPA-HF trial. These were both trials using SGLT2 inhibitors. These drugs that I think everybody now knows about that were first introduced to lower blood glucose in patients with type 2 diabetes that have now become a cornerstone of the treatment of chronic kidney disease, and as we'll discuss, also heart failure. So these trials were both published in the past 2 years. Remember, they included HFrEF patients both with and without type 2 diabetes. So these were heart failure trials, not diabetes trials. Here you can see the primary composite endpoint of cardiovascular death or heart failure hospitalization. This was the primary in Emperor Reduced. It was the first secondary endpoint in DAPA-HF. You can see that in each of these trials, there was a 25% relative risk reduction in this primary composite endpoint. This was a highly statistically significant benefit in each of the two trials. The large relative risk reduction also led to a large absolute risk reduction and a small number needed to treat over a relatively short period of time. Another very important thing to note in both trials is the early separation of the Kaplan-Meier curves after patients started treatment, and in each of these trials, these curves were significantly different within just 28 days of starting therapy. In other words, SGLT2 inhibition is beneficial very quickly within 1 month of starting treatment. Now, there's a lot more defined in these trials. I have not got time to go through it in detail today, but these drugs also improve symptoms and quality of life, prevent worsening of symptoms and quality of life, also slow the rate of decline in kidney function over time in patients with HFrEF. And of course, these benefits were seen when SGLT2 inhibitors were added on top of best available therapy. And because of this, because there are two trials, the SGLT2 inhibitors have been given the strongest recommendation possible in the new ESC guidelines, a class 1 level A recommendation for patients with heart failure and reduced ejection fraction. Now, there is one other recent trial that has led to a guideline recommendation. That is the Victoria trial. This was a trial that used a drug called vericiguat, which stimulates intracellular soluble guanylate cyclase. By stimulating this enzyme, vericiguat leads to an increase in intracellular cyclic GMP, and that has a number of downstream actions that we believe should lead to beneficial effects. So the Victoria trial was quite different than the two SGLT2 inhibitor trials, different because the patients enrolled were at very high risk because of two things. One is they had all been recently hospitalized, and because they all had to have a very high NT-proBNP level, so very high risk patients. The trial was positive. There was a statistically significant reduction in the primary composite endpoint, again, cardiovascular death or heart failure hospitalization. But as you can see, this time the hazard ratio was 0.90. So this equates to a 10% relative risk reduction, a much more modest relative risk reduction. And this was driven by heart failure hospitalization. There was no significant reduction in cardiovascular death. Now, because these were very high-risk patients, the rather modest relative risk reduction still led to a large absolute risk reduction. This treatment has been approved recently in both the US and the European Union, and the ESC guidelines also included a recommendation, a class 2B, level B recommendation. Level B, because there's one trial, 2B, which means may be considered. This relatively weak recommendation was because of the rather modest relative risk reduction and because there was no decrease in mortality, but nevertheless, a new treatment for some patients with HFrEF. And there's been other recent trials that have informed the new guidelines, and these are for the first time ever trials in hospitalized patients that were positive. These three trials, Pioneer using sacubitril valsartan, Soloist worsening heart failure using sotagliflozin, and Affirm-AHF using an intravenous iron preparation. Pioneer was only in patients with HFrEF. Soloist and Affirm-AHF included other patients as well, although the majority of patients had HFrEF in these two trials. So these three trials have led to two important guideline recommendation updates. The first is that all of the important therapies for HFrEF should ideally be started before discharge in a patient who's been hospitalized with worsening heart failure. That's a strong recommendation, a class 1 recommendation. And then the other specific recommendation is that intravenous iron should be considered in hospitalized patients who are iron deficient to reduce the risk of rehospitalization based on the Affirm-AHF trial. So I want to finish by coming back to the treatment algorithm for patients with heart failure and reduced ejection fraction in the 2021 ESC guideline. And you can see here in this green box, so green meaning these are class 1 recommended therapies, you can see the core pharmacological treatments that we now believe all patients with HFrEF should get, if possible, whether you call them the 5 alive or the Fantastic Four. We think that all of these drugs should be given to our patients with HFrEF. But there are three, I think, fundamentally important changes in the way the guidelines recommend we think about using these treatments. The first change is that we no longer believe there is a preferred order or sequence in which treatment should be used. So you don't have to start with an ACE inhibitor or a beta blocker. You could start with an MRA, you could start with an SGLT2 inhibitor, you could start with sacubitril valsartan. The order in which these drugs are used does not matter. The guidelines prioritize getting all of these treatments started before increasing the dose of individual therapies. So start them all, increasing the dose can come later. And that reflects the recognition that speed matters. It's important that we get all of these treatments started quickly, because probably in the past we've been too slow in introducing these different life-saving therapies. So this is my last slide, and it's really to summarize, I believe, the key messages in the new guidelines. These are the 5 different pharmacological approaches that improve survival, reduce mortality in patients with heart failure and reduced ejection fraction. Their mechanisms of action are independent and additive. The goal of therapy is to implement as many of these treatments as possible, as quickly as possible. Dose up titration can come later, and that the order in which these treatments are used doesn't matter. It should not be based on the history of clinical trials. It should be based on other considerations, including what might seem most suitable according to the characteristics of the patients that you're going to treat. So with that, I'd like to thank you very much for listening to this quick update.